To kick things off, we have Brand Newland, PharmD. Brand is the CEO and co-founder of Goldfinch Health. Inspired by personal experiences with the pitfalls of surgery and a lack of proactive solutions to the opioid crisis, Brand helped to launch a vision toward a higher standard of care in surgery and recovery in 2018. Goldfinch Health optimizes the surgery and recovery experience for patients, saving companies, hospitals, and patients time, money, and addiction. Brand has over 15 years of experience in bringing new healthcare solutions to payers, employers, healthcare providers, and patients. Brand received the Doctor of Pharmacy degree from the University of Iowa and holds a certification in pain management. He has also completed an MBA at the University of Chicago Booth School of Business.
Jill, thank you. Thanks everybody for joining us today. We have an important topic in this new CMS model team. But before we get to that, I want to share a bit about background on Goldfinch Health, which we launched in 2018 to help solve this issue of suboptimal surgery. Now, what do I mean when I say suboptimal surgery? Well, to me, that means surgeries with avoidable complications and costs, surgeries that lead to persistent opioid use. It's surgeries that lead to unnecessary time in the hospital and unnecessary time away from life and out of work. There's a lot more detail behind this concept of suboptimal surgery. We'll get into some of that today. But needless to say, there are solutions that can prevent many of these instances of suboptimal surgery. That solution that we're going to spend time today speaking a lot about is called enhanced recovery. This enhanced recovery topic, evidence-based, it's been around for a quarter century, if not longer, leads to the kinds of outcomes we all want for our patients, whether we're the patient, it's a loved one, it's a patient that we're serving in one of our facilities. It's faster, safer recovery. It's faster return to life with fewer complications at a lower cost with greater patient satisfaction. Despite the evidence, and despite 25 years of research in this field of enhanced recovery, we know today it's not as widely adopted as we'd like. It's about a 1 in 20 adoption, or about 5% in the United States. The costs of this miss are huge. They are huge from a financial perspective, and they are huge from a humanistic perspective. Today, we're going to focus mostly on the financial implications of that as it relates to this new value-based model, these bundles around surgery called TEAM. We'll get a lot more into the enhanced recovery aspects in a few minutes with Dr. Alvis. But before we get there, I want to get into a bit more about TEAM, the Transforming Episode Accountability Model, the reason we're here today. Joe, if you could advance to the next slide. Let's begin with the why. The why behind the TEAM model is really what you would expect. It's higher quality outcomes for Medicare patients going through major surgical procedures and better managed costs. That says it very simply. This model is CMS. It's CMS instigated. It's for traditional Medicare patients. It goes into effect in 2026 and is initially slated to last 5 years, 2026 through 2030. What it means is it puts the hospitals that have been selected for the program, the 741 hospitals that have been, you might say, voluntold that you're going to do this, it puts them in a place to be accountable for the initial surgical episode and the 30 days that follow. So initial surgical episode and the 30 days afterwards. Inpatient hospital services, physician services, both primary care and specialist, outpatient therapy, home health services, lab, DME, Part B meds, hospice, all fits into that bundle. Next slide, please. With TEAM, the hospitals are really expected to implement care redesign. That leads to reduced readmissions and emergency department visits. It leads to reduced recovery time, faster discharge for patients, reduced Medicare spending ultimately, and better, more equitable outcomes. We're going to talk about what all of this means. But before we get to that, I think it's important just to take a moment to think about context of where we've been in terms of CMS bundles. Next slide, please. There has been one other model that's worth mentioning, and that model is called Comprehensive Care for Joint Replacements, or CJR. The reason it's worth mentioning, for one, we're going to talk about the surgical episodes that apply under TEAM. One of them is lower extremity joint replacement. So That is a comparator. The other thing that was interesting about the CJR was it was a mandatory bundle model. So facilities were auto-enrolled into this and expected to perform in a way that would lead to savings, and it worked. It worked. It did lead to savings. Now, contrasting that model with what is coming with TEAM, TEAM will impact twice as many hospitals and four times as much Medicare revenue because it goes well beyond joint replacement. But the interesting piece, the hospitals are still at the center of this. The hospital is the accountable organization for performance under TEAM. And an important difference that we're going to talk some about is in this particular case, what's coming with TEAM, the pricing model, how the financials work here, it's a regional pricing model. Past models focused on each hospital's historical spending. So if you were a higher cost facility, you had higher target prices. That is not true under TEAM. Under TEAM, it's going to be based on the region where the hospital is focused. So you're behind the eight ball a bit if you're a higher cost facility within that region. And so we'll talk more about what that means. Next slide, please. So these are the 5 episodes: coronary artery bypass graft, major bowel procedures, lower extremity joint replacements, hip, knees, ankles, surgical hip and femur fracture treatment, and spinal fusion. You can see the DRGs and the other codes involved here. One thing I'll note, for those of you in attendance, we will send out these resources, the slides and related resources in follow-up. So if you're following along and interested in this, we will follow up with this information so you don't have to scribble down notes or take screenshots. We'll get it to you in case you're interested. Next slide, please. So as I mentioned just a bit ago, one of the important aspects of this, and really is a good place to begin when it gets to the financial aspect, is this is going to be a regional pricing model. These hospitals that were selected, the 741 hospitals selected, are selected across the entire United States and across these regions. Now, what you can see here, this is one example of the map. This is one that's related to the lower extremity joint replacement category and shows the fairly dramatic cost differences across regions. That will be highly relevant as we get into this model. The way that the price targets will be set is going to be based on a historical average over 3 years, preliminary price target set in the region, with adjustments made down the road based on actual trend, and semi-annual adjustments to the hospital in terms of their payout. Next slide, please. So the way this is actually going to work, hospitals will continue to bill Medicare fee for service, just like you do today for the qualifying patients, traditional Medicare, having one of the 5 procedure categories, continue to bill in the exact same fashion. But twice per year, there will be a reconciliation measuring the performance of the hospital versus the benchmark, which opens up the opportunity for some additional payment in a reconciliation or some additional cost, some payback from the hospital to CMS in terms of their actual performance versus the benchmark at that hospital. And there will be some additional adjustment as we get more into the nuance we'll talk about here shortly. But that's the overall picture. Set a target, prospectively perform against that target twice per year, reconcile against that target with opportunity for both upside and downside. Next slide, please. So these are the 3 tracks. And I think this is very important to consider today as I guess we're about 9 months out from 2026 and the beginning of this program. So all hospitals have the opportunity, all hospitals of the 741 that have been selected have the opportunity to perform in track 1 in 2026. As you can see, track 1 has the upside only feature. So an opportunity to get into this, get a feel for it, and start performing with some opportunity to gain some additional reimbursement for performance. As we get into the outlying years, so 2027, 28, 29, 30, safety net hospitals can stay in track 1. A certain subset of hospitals are eligible for track 2, which is limited upside downside, and all other hospitals will be forced to move to track 3 in subsequent years. You can see that there is a potential for hospitals to choose track three right out of the gate if they want. And there may be hospitals where that makes a lot of sense. You can see there's 20% upside, downside, certain hospitals that feel well prepared or possibly well positioned, even in their region, based on cost of their services, maybe well positioned to go after some of that additional upside right away in the first year if they like. And so all hospitals will have to make that decision as they head into 2026. Next slide, please. So we're going to take a look. This was from an article, some industry research that's been done that we'd be glad to share. But this looks at the contributors of the cost of an episode, or what's anticipated as the cost of an episode heading into the team model in 2026 and what it looks like across the five categories. And the breakout here is the green bar is anchor stay, then there's a smaller portion for part B, anchor, and then the blue bar on top is post-acute costs. What we've done some of our own research at Goldfinch. We found that about 31% of the cost of an episode, a surgical journey or surgical episode, occurs in the post-acute phase. 31% post-acute, and that's basically what we're seeing here as well. There's some range. It ranges from 14% in post-acute for CABG up to 54% for the hip and femur fracture treatment, but a significant portion, usually around 20 to 30% of the cost of the overall episode happens post-acute. So managing post-acute spending will be critical to the to success of hospitals in the model, as it has been in other value-based approaches. That means managing the right patient to the right setting for the right duration, especially when you're thinking about skilled nursing, you're thinking about inpatient rehab. It also, of course, means managing readmissions. That is probably the place to begin, managing and reducing the risk of readmissions. There's a quality measure that we'll talk about here in a second that also will be a contributor around readmissions. But you can see here that it's not just about post-acute. This is also about managing efficient care in the hospital, and that might mean uh, what can we do to safely reduce length of stay for these patients? Are there approaches that could be employed to help patients better prepare for and feel better supported pre-operatively? That's all part of this picture. Next slide, please. This may be the most important point of the presentation. This is from that same article. What this looks at is this is across, I believe, about 600 hospitals or so that are in the 741 subset, and it projects on average per case whether the hospital would be a winner or a loser, so to speak, if nothing changed, right? If you didn't do anything. And that's probably the most important point I can make today. There is no passive involvement in team. Standing still is not really an option. And it's not really an option because the way that this pricing model is set up is there's a 1.5% to 2% haircut off the top, right? So as CMS is setting up this model, there is a 1.5% to 2% discount that's applied on these episodes to begin with, which means that 60, I believe it was 62% of hospitals are in the losing category. And on average, those hospitals would have a loss, again, if they didn't do anything, of $1,350 per case. Now, 38% of hospitals are on the other side of that ledger, at least out of the gate, and stand to gain, if nothing were to change, about $1,000. But of course, things will change. So this is going to change over time. You can't really sit out the first year and see how things play out because all of the other hospitals may be and probably will be making changes to their cost of care and their quality, and thus the benchmarks are going to totally change in year two. So there's really no sitting still on this. The ground is moving beneath us. No matter if you happen to be on the far end in the blue and you're well positioned out of the gate because you're a low cost facility in a high cost region, so to speak. That could be one of the examples, or maybe you're on the far end of the red here. And you certainly are going to be making changes. Others are going to be making changes as well. But this is going to be a highly dynamic model over time. Next slide, please. In total, there's about $10 million in surgery per year at risk at each facility. That has been estimated at about 15% of an average facility that's been enrolled, the 741 facilities, about 15% of their total Medicare revenue at at risk or certainly in play here related to these surgical episodes. There was an article that's cited here from Becker's that the assumption was based on 25 qualifying surgical cases. So on Medicare, traditional Medicare patients, 25 qualifying surgical cases per month with about a $40,000 episode case. That's how we got to 10 million at risk. So this is a significant portion of the revenue pie at these facilities and certainly worthy of attention. Next slide, please. So there is this aspect of quality magnifier. I sort of think about this as almost as an insurance policy for the hospitals that are enrolled. Everybody's going to be thinking about how can we deliver more efficient, higher quality care at the facility? What can we do post-acute to better manage patients? That's certainly going to be part of this picture. Uh, at the end of the reconciliation, there is going to be this overlay of quality. And you can see 5 measures here. The 2 that are highlighted will be applicable right out of the gate in the first year, all-cause readmission measure and a patient-reported outcome measure for the lower extremity joint replacements. It's an insurance measurement because it it can only improve your performance or reduce the loss if you're falling below or I guess above outside of the benchmark for cost. So it can reduce the amount of payback that you may have or increase the amount of pay into your performance. It's an insurance measure because maybe the financial metrics aren't showing up yet, but you're doing the right things to get there, right? That's sort of the idea here, at least as I see this. You're doing the right things, you're taking the right steps to produce a high quality, lower cost outcome. Maybe it's not quite showing up yet in the cost, but you're on track to get there, and this is helping you to manage that. This patient reported outcome measure is also noteworthy. It's a trend worth following. Will patient reported outcomes or the PROs, will that be a bigger piece of these quality measures in from CMS and in Medicare in the future? That's something to keep an eye on, but it will be part of TEAM in year 1. So how should hospitals get TEAM ready? There's going to be a data analytics component, just understanding where you fit, where you currently would project according to and in comparison to some of the benchmarks that are out there or will be introduced. There's going to be a piece of physician education and alignment. We're going to talk about that here in a moment. Optimizing post-acute care, in particular to reduce readmissions, but also to navigate towards the right patient, right place, right duration as you're thinking about step-down care. That's going to be important to this as well. And enhancing or investing in quality improvement initiatives, like how can we drive better patient satisfaction for those patient-reported outcome measures. Next slide, please. Before I wrap up, I just want to hit quickly on some of the work that we've done at Goldfinch. We've supported thousands of cases over the last 7 years, patients, hospitals, insurers, even opioid settlement funded programs. We've found across the board in surgical cases, there are still a lot of opioids unnecessarily prescribed and used around surgery. Just one example that's top of mind for me, I was recently looking at some relatively new research that was out from a pretty highly regarded institution that was stating that nearly 100 oxycodone pills was still an acceptable amount of pills to prescribe post knee replacement. That's at the same time, and actually several years after, we've seen other research that demonstrates that it's possible to deliver even a knee replacement surgery, let alone some of the other surgeries that are part of this model, the TEAM model and beyond, with very few opioids at all, and delivering a better pain management experience, a better patient experience. So that just says to me there's still a giant disconnect across the United States healthcare in terms of what is the role of opioids and what does that mean to the experience that our facilities have, that healthcare professionals have, and most importantly, the experience that patients have. What we see is that 25% of patients use enough opioids post-surgery to get a refill, to go back for a second prescription. And in orthopedics, which is a major component of TEAM, 45% of patients use enough opioids to go back and get a refill. That is a big problem for a lot of reasons. And if you advance to the next slide, Jill, we'll talk more about that. It's certainly a problem related to long-term opioid use, which is a public health crisis to this day in America. Whether it's the risk to the patient or the risk to the people around them with leftover pills, the risk to the community with diverted pills, it's a big problem. And it's certainly about that. What can we do to help solve that societal problem? But opioids are also a financial problem. as I talked about previously, 31% of total costs of surgery occur post-acute. And a lot of that is linked to excessive opioid use. Patients who have one or more refills after surgery in that post-acute period, they have 2 to 5 times higher costs. They have 4.5 times higher emergency room utilization. They have 1.8 times higher hospital readmissions. That has a lot to do with all of the problems that come with opioids. And I have to tell you that as a pharmacist myself, I don't know that we got really fully educated on this. At least when I was going through my education, we certainly would talk about the risks of opioids related to addiction, persistent use, but there are a whole bunch of other problems, and those other problems are actually the more important and costly problems in the post-acute period. Opioids have been linked to a higher risk of post-surgery infections, a higher risk of post-surgery blood clots. They create an environment for cancer growth. They've certainly been linked with a post-operative complication called cognitive dysfunction, which is highly relevant in the Medicare population. That's deliria and dementia. And craziest of them all to me is that opioids are linked with more pain, this opioid-induced pain that comes with use over time. This is true whether we're talking about orthopedics. It's true as we're talking about major bowel procedures, another category under TEAM. It's true in every category where we've looked. And much of this has to do with patients going into surgery ill-prepared and under-supported. It makes me think, how did we end up here? How did we normalize putting a patient through a traumatic event, surgery, and more often than not now doing that in an outpatient setting, sending them home and hoping for the best? No one's checking in, no one's calling, no one really knows what happens until the patient shows up. Hopefully, they don't show up back in the emergency room. We're crossing our fingers. They don't show up back at the hospital, and we're rounding on them in 2 days. We're hoping for the best, and we'll see them in 2 weeks or 3 weeks. We'll see them at their follow-up appointment. And it makes me think of this quote that I've seen many times, which is every system is perfectly designed to get the results it gets. And that is exactly what we're getting out of this system, that we're getting a system that's delivering subpar results, which is really, I'm sure, why CMMI and CMS has looked to bundles and this value-based care arrangement to try to drive better outcomes and lower costs related to these surgical episodes. I'd like to suggest, as we look here to transition, I'd like to suggest that the same formula for solving our opioid crisis around surgery and right sizing the size of an opioid prescription, setting patients up for better success, that is the exact same formula. Multimodal pain management, better management of pain with fewer opioids. That's the exact same formula for success in TEAM. We're going to talk more about that next. So let's bring William in to discuss.
I will introduce our next speaker. We have William Kiefer. William holds a Bachelor of Science in both microbiology and nursing from the University of Texas at El Paso and a Master of Business Administration from the University of Phoenix, receiving his DNP degree from Texas Tech University, focusing in executive healthcare leadership. He has also received recognition from the American Nurses Credentialing Center as a nurse executive advanced for his dedication and knowledge of nursing and hospital leadership, and most recently joined the American College of Healthcare Executives. Kiefer possesses many years of experience in healthcare management, working in various rural communities where he has strived to increase and improve the delivery of healthcare services. He has served as Chief Clinical Officer, Chief Operating Officer, and Chief Executive Officer, achieving meaningful results in quality and financial outcomes.
William, thanks for joining us today. I'd love to hear your reaction to the model we're talking about, TEAM, and some more information about the work that we've done together around opioid quality improvement and how you think it might apply to what we're talking about here in terms of value-based approaches to care and bundles in surgery.
Thanks, Brent. Appreciate the opportunity to share my experience working alongside the great partners that I found in Goldfinch. And this is a very important topic as Brent took us through TEAM. It's no surprise to me that we have yet another opportunity as healthcare leaders to raise the bar when it comes to outcomes. Unfortunately, many times as we are asked to raise the bar, that comes with the potential for financial penalties. And it's, again, no surprise that those are aimed at hospitals, where the majority of the most expensive procedures take take place. And from the CEO perspective, it's certainly something that catches my attention when CMS is looking at bundling and looking at reducing or penalizing us in the surgical services area, because that's where many of us stand to make the majority of our profit in the inpatient setting. And so it is certainly worthy of our attention, and it's a great topic. So I appreciate the opportunity to be on this panel. So here, I'll take you through some of my experience and let you know what we did as we partnered several years ago with Goldfinch and some of the results that we've experienced at my organization. So here you can see the flow chart related to the work that we did in enhanced recovery after surgery, but also which is a model that's helped to reduce the amount of opioids that are prescribed following surgery. That's one of the outcomes. So you launch, there's education that's provided, and then there's, most importantly, I think there is discussion with the patient on what to expect and education given preoperatively by a nurse educator, and then again postoperatively by Goldfinch nurses. And they check in with the patient again, both preoperatively and postoperatively, make sure that they're aware of the things that are happening. There are many questions that patients have post-op. Is it normal to have redness around the site, the incision site? We have a lot of patients that just don't have any information or knowledge when it comes to what to expect. And having these advocates as part of my team, we've seen a reduction in emergency room visits postoperatively, which is extremely important, not only when it comes to the overall expenditure of healthcare and resources, but also with some of the measures that we're talking about that we're going to be judged on when it comes to team. And so certainly very excited about our work together. And if we can advance, I'll share some more of our results. So you can see here that as we partnered and as we did this education, we had almost an 80% decrease in the reduction, a decrease in the prescription of opioids following surgery. And if you stop and think about that, we get hit with so many statistics. That is, we decreased the average amount of opioids that were consumed by our patients postoperatively from about 62 pills down to 13. That is significant work that our providers did, that our nurses did in conjunction with the Goldfinch team. We could not have done this work without them. And so we're really proud of that. We were an organization that sits in a community that is heavily addicted. And so I was looking for a solution. How do I help my patients postoperatively to utilize less opioids, to put less opioids out into the community that can be utilized in a nefarious way potentially, or that can cause addiction? And we all know that having additional opioids out in someone's home or in the community is never a good thing. And so I was actually introduced to Goldfinch by our hospital association president in Iowa. And immediately I felt that this was a worthy cause. And these were things that I was very interested in pursuing for our patient population. So again, going back to these results, you can see that our use of opioids dropped to 16 from a benchmark of 27. And our refill, this is also very important. We were refilling patients' prescriptions at a rate of 90%. And we dropped that down. Well, sorry, we're able to drop that refill reduction down to by 90%. And so I believe in our particular case, we were having about 5 refills, and we decreased that down to 1 refill per patient. And so a really significant decrease. And then we have a less than 2% visit to our emergency department post-surgical, which is great. And if you compare that to the state average of 7.5%, you can see that we are far exceeding that, which in the terms of this conversation is very important, because you can see our work with Goldfinch has put us in a great position when we're going to move in as a voluntold hospital in the team model. We are well positioned to perform well in team. So thanks to Goldfinch and the partnership. So we can advance again. And this is just a graphical representation of what we've already gone through, from 62 pills down to, you know, less than 10, and the reduction of the refills there from 2.1 all the way down to less than 1. So super excited about all of that work that was done. We can move again. And just some quotes here that you can read from patients, but I've spoken to patients about this work, and also championed this work with some of the nurses in our clinics, and heard from them as they interacted with patients how grateful patients were that, one, they were better prepared for surgery because of the nurses that were reaching out to them, explaining to them some of the things that you're going to hear about in the ERAS protocol right after me, what to expect, the things that they should be doing, and measures that are evidence-based that they should be doing preoperatively to prepare to have better outcomes after surgery. And then after surgery, again, having those touch points with nurses that are as a first call, I would say, if they have any concerns, instead of just jumping into the emergency department or having to go back into the doctor's office, they're able to easily and quickly pick up the phone and call the Goldfinch nurse that we were partnered with, and many times have their concerns allayed and not needing to go back into the emergency department. So you can see that we've had some great success from our partnership with Goldfinch, and certainly very appreciative of that. And I'll go ahead and turn it back over.
Wonderful. Now, like William alluded to, we do have Dr. Brett Alvis to speak about enhanced recovery after surgery. I'll give you a brief introduction as well. Dr. Alvis is an associate professor of anesthesiology and biomedical engineering at Vanderbilt University Medical Center and the former medical director of anesthesia, perioperative clinical service at the Tennessee Valley Healthcare System VA Hospital. A nationally recognized expert in enhanced recovery after surgery and perioperative surgical home models, he led the development of an ERAS integrated perioperative care service at the VA, significantly improving surgical outcomes, reducing opioid use, and shortening hospital stays. His translational research in perioperative medicine, enhanced recovery, and cardiovascular monitoring has positioned him as a leader in the field, and we are happy to have him to talk more about the value of enhanced recovery after surgery.
Dr. Alvis, thanks for joining us. We've been talking a lot about this formula for higher quality surgery and recovery, better pain management, fewer opioids, and all the other positive outcomes. What is enhanced recovery and how does it work?
Yeah, excellent. Thank you for allowing me to be part of this panel. Anytime I'm asked to speak to enhanced recovery, I get excited, and so hopefully I don't talk too much. But ultimately, to answer your question specifically, enhanced recovery after surgery is as it says on the slide. It's a multimodal perioperative care pathway designed to achieve basically early recovery of patients that undergo surgery. And so I think it's best to understand ERAS by kind of going back so that we can understand where we're going, if that makes any sense. And basically, the model I was trained on was very fragmented. Back in the early 2000s, it was a patient was scheduled for surgery with their surgeon. They came to see an anesthesiologist in their pre-op clinic. They then showed up that day. They were under the care of the anesthesiologist. The surgeon did their thing. And then ultimately they went to the floor and they're back in the hands of the surgeon, and various people like physical therapy and stuff put in their recs. But it ultimately, no one really knew what the other people were doing. And so what, as things like bundle payments started to be discussed and become a thing, where I was at Vanderbilt University Medical Center, we started seeing outcome come from Europe, where they were starting to think, well, let's organize surgery from a fragmented approach to a more linear approach, where the key players involved in surgery like come together and say, let's look at what the evidence says we should be doing for these patients, and ultimately organizing the pathway in such a way that we appreciate the surgery starts at the time you schedule it to the time that patient is fully recovered. And so ultimately, which doesn't sound too complicated, but ultimately we started to implement that at Vanderbilt and and roll out enhanced recovery pathways where we started looking at the evidence to say, well, what does the evidence say with regards to pain management? What about fluid administration and NPO, or the times at which we have the fasting times for patients, certain pillars and certain key metrics started to really start to develop where we identified obvious opportunities to organize things in an evidence-based way that started demonstrating some significant outcomes, which I'll get to. So next slide. And so speaking to these outcomes, when we started executing enhanced recovery for more and more surgeries, every time we did this, and then when we moved, when I got recruited to the VA and we started um, an enhanced recovery surgical service over there as well, led by anesthesiologists and nurse navigators, similar to the Goldfinch model. We started demonstrating again repetitive outcome improvements. What are they? Length of stay shortening. So patients were in the hospital for shorter periods of time than they were prior to the implementation of enhanced recovery pathways. Less opioid use both in the hospital and out. Less 30-day readmissions despite performing more surgery and having shorter length of stay. We had less 30-day readmissions into the hospital and less ER visits. And ultimately, when tracked, we had better patient satisfaction scores. And so these outcome improvements have, over the course of the last 15 plus years, where they've really started to spread mostly in academic centers that are publishing them on the results, the same results are seen. You see reduced readmissions, you see improved in opioid use, you see shorter length of stays that result therefore in more surgical production and better patient experiences. These have been repeated time and time again. Next slide. And so here, I'm going to outlay just a couple studies, but there is no shortage of them anymore that do demonstrate, when implemented for any type of surgery, whether it be whether it be colorectal surgery, kind of where it got its start, to orthopedic surgeries, to cardiac surgeries, spine surgeries, whatever. When they are implemented, I should say, around some key pillars that we'll get to, that there is continuously demonstrate shorter length of stays. Here in this paper, they showed 20% improvement in same-day discharge, 65% reduction in readmissions, 53% reduction in opioid refills, 74% reduction in unplanned visits, and then 60% actually fewer phone calls, which I found interesting that in this publication, they actually tracked fewer phone calls, which is also important as someone that has to carry a pager. The fewer times paged, the better. And the next paper will show, again, demonstrates a repetition of these outcome improvements. And when we studied this at my own institutions, we published the same type of results and outcomes. And where basically, where we continuously demonstrate that enhanced recovery really allows for a maximizing of the care of the patient and minimizing the cost. Next slide. And so, what are kind of these pillars that are implemented in enhanced recovery, and the interesting thing is they're not real game changers. They're pretty simple things that weren't done, but when they are done, have huge results. And so prehabilitation, that again, an understanding that surgery isn't just when the knife goes on the skin. Surgery happens when it's scheduled. So you have pre-surgery patient education. You help improve the health literacy of that patient prior to the big day. And so setting expectations, pain isn't a zero-sum game where you're going to experience some, but what should you expect? What are we going to do about it? And really, what is the expectation when it comes to your pain management? What is the expectation when it comes to your activity level? What is the expectation when it comes to your diet? Stuff like that. And then pre-surgery nutrition. The amount of surgeries that don't follow the actual guidelines of oral intake is astronomical in this country, and extremely unfortunate. Time and time again, when a patient is appropriately hydrated prior to their surgery, outcomes improve. And I'm happy to speak to what those outcomes are, but there's a multitude of them. And so with enhanced recovery, it basically just reminds every enhanced recovery protocol that I've ever been a part of reinstitutes the guidelines set by the American Society of Anesthesiology that you can drink clear liquids and very effective clear liquids in nutrition, like a Gatorade, for example, up to 2 hours prior to surgery, barring certain types of diagnoses. And by doing that, you're going to have you're going to improve a lot of outcomes. The next pillar is multimodal pain management, an absolutely key pillar of enhanced recovery. And that it basically, when you look at the evidence, it's how can we approach someone's pain that's not just opioid, with just opioids, not just the mu receptor from a scientific standpoint. And that is, well, there are a lot of other ways in which we can. It's regional anesthetic techniques, using numbing medicine, using non-steroidal anti-inflammatories, using gabapentinoids, using other receptors that are in our body that are affiliated with the pain pathways. And so when these are implemented before, during, and after surgery, they have time and time again demonstrated a reduction in opioid use, a reduction in refills of those opioids, as well as a reduction in pain scores and improved patient satisfaction. Next pillar. And then post-surgery support. All of these are very important, but this one is really important. This is extremely an important pillar with enhanced recovery, because again, just like it is understanding that it starts at the time of the scheduling of the surgery, it doesn't end until that patient is back to normal, back to work, back to living their life. And that does take support outside of the hospital. And so having an expert nurse navigator and having a care plan that a patient can understand, and not just assuming that everyone gets it. Everyone has the same health literacy, which we know is a fallacy, is a key cog for success of enhanced recovery protocols. And one of the key aspects of Goldfinch Health that really helps in its success. And so ultimately, there are 50 plus additional elements. I don't have that time, but obviously, happy to discuss any in the time during the Q&A. But there's a lot to these. These are the three kind of big ones that we focus on. But ultimately, enhanced recovery is time and time again, when instituted, is a very effective way to maximize the care and minimize cost for patients, and really give them the experience that they ultimately deserve, in my opinion.
Dr. Alvis, thank you. We do have some time for questions. Jill, I'll turn it over to you.
Thank you. Yes. As a reminder, if you have questions for the panelists, you can use the Q&A function at the bottom of your webinar panel. Go ahead and submit those. The ones that we don't have time to get to today, we can certainly follow up with via email as well. Okay, question for William. As CEOs of hospitals, how do you initiate this conversation with surgeons and staff? What do those conversations peer-to-peer look like?
Yeah, really great question. So we wanted to, after I was introduced to the program, I thought, wow, we really need to be doing this. Enhanced recovery, it's evidence-based. We need to implement this as quickly as possible. And so in my conversations with Goldfinch, I asked the question, how do I go about doing this? Because I have surgeons that were trained a very specific way, and they've been out of school and they've been utilizing their training methodology for years. How am I going to help them understand this, embrace it, champion it, and then implement it? And so luckily, there's a great group of professionals over at Goldfinch from the administrative support team to Dr. Alvis. We invited him to join our surgical department committee meeting, and he was able to take our physicians. We had orthopedists, general surgeons, OBGYNs, others that were in the room. He was able to take them through the ERAS protocol in much more detail than what we just covered here, and really have a peer-to-peer conversations with those surgeons, and most importantly, share from an experience standpoint what he was able to implement and the success that he had in his practice. And so that was really great. And there was, aside from the presentation, there was also opportunity for Q&A, and he was able to answer all of their questions. And at the end of that meeting, when he and some of the others from Goldfinch jumped off, our surgeons unanimously voted to move in the direction of implementing ERAS protocol and partnering with Billion Pill so that we could achieve the results that we went through earlier. And so it was really very easy from my standpoint. All I had to do really is invite the Goldfinch partners to join our meeting, and they took it from there. And we just partnered alongside them, and we've had some great outcomes.
Little more basic question. If a hospital that is not on the 741 list chooses to participate, is there time for them to do that? Is that an option, Brand?
Well, they could have, but that time has passed. I believe the deadline for a hospital that wasn't in the 741 hospital cohort to say that they would like to be included was January 31st. So that ship has sailed, but there will probably be other opportunities in the future, I would guess.
How does health equity fit into the team model?
I can take that one also, Jill. Thank you for bringing that one up. So that was one of the initial stated goals of team was to improve health equity, and there are several aspects to team and the model that has been created that focuses on health equity. For one, uh, the hospitals that were selected in the 741 were widely distributed across those, I believe, 8 different geographic regions. And they went to lengths, as I understand it, CMS, to include safety net hospitals that may be serving a disproportionate number of vulnerable patients for one reason or another. And so that was one aspect. This is uh, by the virtue of its mandatory nature and the lengths that they went to in selecting hospitals, there will be more vulnerable patients incorporated into with access to these value-based arrangements. That's number one. Number two, hospitals that are in the 741 cohort participating in team will be required to submit a health equity plan each year, which I think is an interesting aspect to this. Health equity plan that will include goals, intervention strategies, performance measures. One of the interesting things about enhanced recovery after surgery protocols that we just spent some time talking about, there is a whole separate body of research that focuses on how enhanced recovery improves health equity and reduces disparities in healthcare. It's kind of this idea of a checklist manifesto, so to speak, in delivery of a surgery pathway. And so these actually align. That implementation of enhanced recovery also fits into a health equity strategy and how you're going about reducing disparity. So it fits very nicely into establishing goals and performance measures around team.
A few questions related to enhanced recovery after surgery. Going to pass these to you, Dr. Alvis. Can be a daunting process, like you mentioned, lots of pieces here, but given the short timeline that the team hospitals are under, what particular areas of ERAS should they focus on?
Yeah, good question. I would say the first answer, based on my experience of starting these and implementing them on multiple surgery lines, is you focus on what you focus on what you can focus on, basic. And what I mean by that is there are obviously these pillars that we talked about, the prehabilitation, multimodal pain regimen, fluid administration, and then activity levels. It's a kind of identify what your hospital and what it does, what you believe it does well, where you'd like to improve with an understanding of the with an understanding of what these pillars are. So and they're out there. They're easy to find. There's multiple publications on enhanced recovery. There's even a society webpage that has them for multiple surgery lines. But ultimately, most people start with pain management using multimodal approach that doesn't focus purely on opioids. It focuses on following the guidelines of nutrition. It focuses on early activity, and so don't the old dogmatic practice of leave them in bed until they're healed. It's is getting rid of that and putting the resources in place to be able to get rid of that. And then it focuses on a more organized approach of follow up so that you can answer questions effectively and outside of the ER. Ultimately, those are kind of the big hitters, but again, if those aren't something we can't focus on and put resources in that time because of our various limitations at this center. So like as you can imagine, at the VA versus Vanderbilt, different hospitals, different type of resources to use. You focus on what you can do, and then you start doing it, and you're doing it every time the same way. And then you just start adding more and more as you can.
Great, thank you. Maybe a question for Brand here. Where or how do you see Goldfinch support or adoption of the ERAS protocols affecting team scoring and reimbursements?
The direct impact is in readmissions. In particular, it's the reduction in readmissions related to pain. That's the number one reason that a post-surgical patient ends up back in the emergency room or back on the floor of the hospital is uncontrolled pain. And so much of that is related to under preparation, under support, misunderstanding, maybe not having appropriate expectations set around what is concerning pain and what is normal pain. What is the experience that you should expect in a post-surgical experience, and not understanding maybe exactly the other elements of a multimodal pain management strategy, which oftentimes is based and begins with medications like acetaminophen and ibuprofen. Acetaminophen is Tylenol, usually at a higher than over-the-counter dose for a short period of time, and oftentimes that's combined with an NSAID like ibuprofen or Aleve. That can go a long way in a pain management strategy, but you have to do it, right? You have to understand how it works. You have to understand that when you're taking it and understand that you're using it at kind of baseline and then only advancing to some of the other options, including opioids, when and if needed, if that's not getting you there. So a little bit of support can go a long way in that post-surgery period, and that is how you head off a readmission early. And even if a patient does end up needing to go in for follow-up care for some reason, it's always better to catch that at a time when they can be seen in clinic at 2 p.m. on a Wednesday rather than 2 a.m. on a Thursday morning, right? If they sit around for 12 more hours and get increasingly anxious about it, and that maybe it is a true complication that's advancing, that's not good for anyone if that patient is coming in the middle of the night with an emergency. So let's head that off early and get that patient in to be seen as soon as possible. Those are the places where I think we can lean in right away. There are some other pieces, of course, when you think about what Dr. Alvis is talking about and full implementation of enhanced recovery protocols, where we can bring some expertise to bear on what's actually happening in the OR where we are, but the healthcare professionals involved with that patient's care are. We can help there, but I think right out of the gate, it's reduction in readmissions.
Thank you, Brand. We are about out of time here. Probably gonna close us here with some conclusion remarks. If you have any, Brand, obviously Team 2026 will be here before we know it, and hope that through this presentation, we've helped hospitals to feel more prepared for what that brings. Anything additional to add, Brand?
Yeah, just a couple of closing thoughts. What we're really focused on and what we do is when it comes down to it, it's patient support and it's implementation science of something that's already widely supported in the clinical data. There are a number of innovations that are happening out there. You maybe have seen them in the news. There was just a new non-opioid pain medication approved for the first time in, I believe, 20 years. That was a medication called suzetrigine that's coming. That's one example of a medication that could be part of some of these regimens in the future. Multimodal pain management, bringing in non-opioid alternatives. There are some that exist already today. Regional pain blocks that are used, long-acting local anesthetics like Exparel that are sometimes used in these pathways. All of these are tools in our toolbox for helping to deliver a better experience for patients. There are also policy changes that are happening separate from TEAM, but are also sort of in the same lane. There's something called No Pain Act that was approved uh, a, a year plus ago and now in implementation, which provides for reimbursement opportunities for non-opioid alternatives to pain management. Fits right into this, right? That this is an opportunity for reimbursement related to helping patients through these painful experiences like surgery with fewer opioids. So I'm offering that just to say that there's a lot of momentum in this direction. Just need a little push. The value-based model like TEAM is another push in the direction of how can we better support patients with evidence-based protocols and fewer opioids. I close by saying we're here to help. If you'd like to have a conversation and learn more about some of these resources or get pointed in the right direction on enhanced recovery after surgery, we're glad to talk with you and point you in the right direction. If you're interested in kind of a full systematic approach supporting your facility and system and making these changes in a sustainable way, not only potentially to the benefit of the Medicare patients that are going to be enrolled in TEAM, eligible under the value-based model, but well beyond, right? These same principles apply for every patient who's coming in, not just the Medicare patients who qualify under TEAM. We'll be there for you there as well, and talking about how we can better support patients, bring technology and resources and other expertise to the table. But please reach out. We're here to help. And we really appreciate you taking the time with us today. We will follow up with each of you so you have an access to these resources and the recording of the webinar, and look forward to chatting with you down the road.